you've extubated and you're just like ready to leave, your day's done. And then all of a sudden the sats are dropping. And all of a sudden I'm like, or do I need to do a crike here? Like, what's going to happen with the airway? And then it's all fine at the end. And then you just go home and you're like, then the next job, which is being mom. And they don't care what you were doing. They don't understand, nor is it their job to. I don't expect them to. I don't even want them to. I want them to want me as mom. But how do I show up as mom when I've given my all to something else?
Welcome to the Too Curious MD podcast. I'm Dr. Ali Ahmed.
And I'm Dr. Soraya Arfan.
In this podcast, we are asking the unasked questions.
We're physicians applying the lens of narrative medicine, exploring integrative practices and psychedelic treatment in healthcare.
Together with our guests, we weave new learnings from stories, expertise, and the sciences. With the wisdom from holistic, alternative, and these conventional medicine, we are here to challenge the status quo.
We're curious about the connectivity and complexity between diverse fields of knowledge as they relate to consciousness, chronic illness, mental health, resilience, and beyond.
Learning more about the art and science of healing, or listening to stories of extraordinary healing. You're in the right place. Let's dive in. Welcome to the Too Curious MD podcast. Today, we're excited to interview and really query Farah Karipineni. She is a doctor and endocrine surgeon in Fresno, California. She's an associate professor with UCSF Fresno, an avid writer and wife and mother of 3. And that is, to put it very simply, she actually is a profound healer and really has a lot of contact and a lot of compassion for her patients. And today we'll be talking to her about things that bring her to this space in this podcast. Welcome, Farah. How are you?
Thank you. I'm good. I'm excited to be here finally to talk to you guys about this, which I think is a really important thing that you're doing. So it's really lovely.
Yeah, it's been a journey. I think we continue to meet very unique individuals with unique perspectives. Integrative medicine really brings in a lot of the different components of healing, some things that we don't necessarily get in medical school, and often are learning into things that really have an impact. And I think that is why this podcast brings in the element of story, the element of the things that we sometimes don't really pay attention to until we do. And I know you have written about this, your personal story, the stories that you encounter in your training as well as in your current practice. Also, your avid awareness and sense of compassion, even in difficult times. I remember in COVID how difficult it was to really be in the operating room and the things that changed, and your dedication to your family, to your kids, a mother of 3 and twins at the same time. And have really come through your own personal experience and your own personal, sometimes challenges, to the place that you're at currently. So thank you for being here.
Yeah, I'm so excited. Thank you.
I have so many questions that, there's so many realms that we can start with, but I think we can maybe start with the realm of writing and what writing means to you and how it's come to take a role in your life as a physician, as well as a mom, a storyteller. Like what's its role in your life?
Yeah, I mean, I came to writing very early. I was a very non-traditional med school applicant in that I majored in comparative literature. So writing was a big part of my undergrad major, and it was very specifically in comparative literature, like you're comparing works from 2 different genres or 2 different even languages sometimes, and kind of like finding universal truths. And when you're comparing 2 things, you find the comparisons and the contrasts, and the stories really come to life. And I focused on colonial and post-colonial literature, so it was even more so about social justice a lot of times, and stories that are told with the vehicle of fiction but are not truly fiction. And I felt like I was fighting for justice in some of those papers that I was writing. And I just think writing is so powerful. It's such a powerful thing to do. And I brought those narratives of social justice with me everywhere. And of course, I would bring them to medicine because that was part of my path to medicine. So, of course, being in medicine and experiencing what we experience and not really having another outlet that really can do justice to the depth of the feelings that we experience in residency and in attendingship. And I have a surgeon father, a surgeon husband, and an OBGYN mother, and any number of like cousins. But there's still some times where I cannot find somebody to really like sit in the depths of it with me. And that's like the perfect space for writing.
Yeah, absolutely. I'm brought to, I think all three of us share the love of Abraham Verghese, and you quoted him in one of your papers. I just really love how blending the medical with the literary. It's been a genre for, since the beginning of whenever, physicians were writing. There's a great tradition. So I feel like we're kind of following in the footsteps of that and kind of making it like a modern version of that, right? Like Chekhov and, his invention of the short story and just the fully realized characters that are our patients, right? Just the characters of human exist, that are just existing, and some of the follies and foibles and, just these complex ways in which people show up, and how that takes takes such a big heart, right? It takes a broad perspective, but also a big heart to kind of hold all of that. And I love that generosity about literature and how that can, when we infuse that back into medicine, I think it really does help us to humanize the spaces we're in. So I really love this. How else have you kind of brought that, how have you discovered the ways in which it shows up for you in your everyday practice or in your teaching or, as you're sitting around with your colleagues, how do you bring that in maybe?
In the writing specifically?
Or just that perspective, even like the perspective the writing gives you.
Yeah, I mean, I think it's just like the humanity of understanding that everyone has a story is so important because it doesn't necessarily translate into how they show up. They might show up anxious, they might show up rude, so many different ways, and we can choose to respond to the rudeness or the anxiety, especially in modern medicine right now. Before the patient comes to a subspecialty office, a lot of things have had to happen, and they've waited a long time, and they know something's up because they're in a surgeon's office, but it's taken a really long time to get here. And now I've given them, probably 10 to 12 of my minutes is allotted for them. And the expectations are actually so low. It's heartbreaking how low the expectations are in medicine right now because of how people are being treated. And so just to remember that like this person exists in a sphere. They are somebody else's entire world, just like I am somebody's entire world. And they have a story. And we're just connecting in this space and time in this one moment. And it's actually a really sacred thing. And if I don't like seize that, if I let it pass, then I've missed something. And if I don't want to be a part of that, then life is too short. Just find something else you do want to be a part of if you can't be present in this moment, with this patient, with this surgery, which whatever. It's a privilege for me. And so I think it's just building that story. Like we all have our stories. And I think about this to my kids all the time because like I read this somewhere where it was like, if you understood the reason behind a child's bad behavior, 99% of the time, it wouldn't make you angry. It would break your heart. And obviously kids can't like say what's going on all the time. They can't always tell it to you and like they can't wrap up their story with a bow and give it to you, but you have to be able to think beyond that if you're truly going to inhabit space and time. And that's a gift you give yourself.
I love that, and how the imaginal is that muscle that we can build, right? Like reading those long novels, spending time in reverie, sitting with characters, getting inside of the skin of another character when you're reading imaginative work, I really think is a practice that, when physicians ask me nowadays, what should I be doing? I'm like, read novels. I really think that is one of the ways that all three of us, I think, have arrived at this place of where humanism gets taken out of that interaction. And you're so right in labeling it the sacred moment. If we can show up in that moment fully as ourselves, it's powerful. It's bidirectional, powerful. It has meaning in your own life as a physician. It's like I was able to meet that moment. It was a difficult moment.
Yeah.
And
Because it's people don't understand that, and the power of like investing in that is that they will get something out of it too. I don't think it would drive you enough if you think it's going to be good for your patients. I think it has to be something where you realize that you're going to get something big out of it as well. And I think that's the only way that you can actually see the value of it. It's just showing up as your authentic self everywhere that you go.
Yeah, I love that. And it reminds me of what I learned from watching my dad just as a young child, a child around two physician parents who were, in a new place, doing the immigrant life thing, but also, and I'm sure you've, seen some versions of it. But when you see that the interactions in their lives mean something to them and how much we end up taking home, right? Like physicians really end up taking everything home. It shows up in some way or the other. And, as a child, I got to kind of watch that and recognize that how deep it goes and how hard it is to separate from that. But then it also becomes a part of your character, which is another layer of, especially because when it means something to you, when you arrive at it and you engage with it as something that really feeds your own soul.
Yeah. I think I came to writing really not, I never did write as well because I was in engineering. I did not do any writing. To me, writing was very difficult and very, very extracting, very emotionally, like just, expelling sometimes those emotions that you kind of really push away. I'm curious to know, what were your trigger points? What is the story and how does that story arrive in your mind, and how does that feel as you extract that or even put it on the page, the story?
I think it's really tricky because for me to say, because I mean, most of my life is just a hot mess, like running from one place to another. It's not like I like sit down and I'm like, oh, like I'm gonna write this story, but I think there's certain moments that just like push me to that point. And so the trigger point is whatever happened in the way it has me feeling, so it could be an unresectable tumor, the trigger point of just that feeling that I can't do anything. Like the point is to do something, like that's my job, and it's the point is to be perfect at it. And then there's sometimes you just can't, because if you did, you'd have a perfect resection and you'd have a dead patient. So that's obviously not going to work. How does the surgeon reconcile those two completely disparate things? So that might lead me to write something about that, because there's nothing anybody can do about it. And there's a perfectly logical explanation for it, but it doesn't change the way I feel.
Yeah.
Something like that.
And it really goes to the ethics of caring, right? What arrives when you are in that state of, it's a quagmire, you've got two different discordant ideas and two different areas of dilemma, really, the dilemma of a situation, and really kind of sometimes working through that, through story and through kind of that representation of what really is happening, kind of that broadening that window of what is observed than just what we think we're seeing in that 5, 15, 20 minute of that experience.
I love how we're dialogue with the self, right? You're kind of having a dialogue already. Like there's a situation and it triggers something.
Yeah.
It triggers because of the ethical stance, because of how you're seeing the conflict. You're seeing the energy being like, oh, this is exactly what I was ready to do, but now I have to stop, and I have all of this stoppingness that I need to sit with. Why am I uncomfortable with that? And exploring that and yeah, just crystallizing it, not needing it to resolve.
Yeah. Yeah, like bearing witness, bearing witness, and nobody, like there's a lot of talk about self-compassion. We want someone to, I guess, bear witness to our struggles, and everybody wants that, right? Like my kids want that half the time, that everyone wants to be heard at the same time, And so like self-compassion with Kristen Neff, I don't know if you're familiar with her work, but like the idea that you can be that person for yourself. And for me, I feel like sometimes writing is part of that. It's just an indulgence in bearing witness to myself, because what's so hard to me about especially not just medicine but surgery, where the outcomes are like so fast to see, like surgery, like right away, is that the lows are so low but the highs are not high. You don't experience the highs high at all, almost nobody does. I mean, there'll be some grateful patients. Probably the best note that was ever written to me was a patient's lipoma. And I've done a lot more complex surgeries than that. But she said I saved her life. And I've actually truly saved someone's life, but that was not the patient. Most of the time, it's just like, oh, yeah, she said it was going to be like that, and it was like that. But then the lows hit you so hard. And then you're like, well, there's what's on the other side of this? So the 1,000 patients, and there's this one, so like you have to give yourself somewhere to bear witness to that.
I love how you described that the wins are kind of that they're the average. They're kind of like the everyday pattern of things. It's like we only notice when something is really off or pattern, and then it becomes kind of like it goes deep.
Yeah, and then I also think, why didn't I think, I mean, I believe in God, and why wasn't I so grateful for each one of those? Why didn't I celebrate the 1,000 times that it went well?
Yeah.
Why didn't I? So I mean, I've thought of this, but I haven't actually done it to really if I walk out of the OR, those 6 cases went well, to just write a list of all the things that went right for that patient that day, and all the things I got to be a part of that were truly a miracle. Because most of the time I just drive in my car and just run off to the next thing I'm doing. Yeah, that's how it's supposed to go. But really, if you really think about all the things that had to go well for everything to happen okay for those patients, the vast majority of the time it does. It is a huge blessing.
Yeah.
And I should be so grateful.
And not just you, I can see kind of like a ceremony at the end of every surgery where you could kind of just be like, we got all of these things right, guys, and just do it as a team, even because I'll just do the next thing. You're absolutely right. And it's just the way it's structured. It's just the way our reward system is structured. But what it takes away from us in just falling into that default, or it is to just kind of forget the everyday miracles that are happening every single minute.
Yeah. And for someone who truly loves their career, I feel like that can actually add to longevity too, because after a while, everything becomes really routine, and then it becomes like, well, how fast can I do it? And I can do things really fast. But then I some days I'm like, don't forget to actually enjoy it, to just savor that, you're not worried. You know how to make this cut. You know how to do this thing. You know how to avoid that complication. Enjoy the process of doing it. The beauty that is how the beginning of, I forget which book, maybe it was Cutting for Stone, the way he talks about the surgeon agape at beauty of the anatomy in the belly. That's exactly how I feel. But sometimes you forget to enjoy the massive privilege that it is to do what we do. That can lead to it cutting it short because you've distilled it into something that no longer resembles the magic that it is.
And isn't it amazing? Everything can look the same. The setting can be exactly the same, but something can be as sacred, right? And kind of lit from within with a certain kind of light, just like you see in some of those paintings,
Yeah.
The position of the bedside. Or it can be seen as kind of very grotesque or very kind of mechanical or devoid of that. And it is what we imbue it with. It really is that kind of.
It's interesting because as a surgeon, I mean, there's a different level of intimacy. You see the patient first before the surgery, and then you see them in the surgery. I mean, and that access to their inner self, the body, that contact, that delicacy and the intricacy of that procedure that you've described to me before, how meticulous you have to be at the same time. And then even then the closure of that surgery, and then the after post monitoring and the post effect, and that there's such a differential arc that I think shows up in what you describe versus what as a primary care provider it would be very different. That relationship would be very much about just relational, that contact, that medication. But as a surgeon, there's that extra layer of intimacy, I think, that shows up, and I don't know how that feels for you, if that comes up in your writing.
Yeah, I mean, I think the issue of trust and connection feels, and of course I don't know how it feels in any other specialty, but it feels paramount to me. The trust is paramount, as a woman of color, as someone who, you said that I look young. I feel like there's counts against me at times, and people will sometimes say stuff like that, but people also within minutes will sometimes say, are you the one doing it? Because I trust you. And I think they're asking me if I'm the one doing it because they want someone else to be doing it, but they actually want to make sure it's me, and they've just met me. I think that like there's something in the connection, like they can tell if you care. They can tell if they have your full attention with so many little details that happen in the room within seconds. Because it's not like I'm in there for very long because I just don't have that. I don't have that luxury. Got 40 patients, 8 to 4, do the math, it's not long. And then you have a resident with you. So, but I think as far as like in focusing on that trust and the connection. So they have to know that I care about them. And I'm not there to treat their diagnosis, but I'm there to make their life better. And then the part about trust, like, can you trust me? And I think that those two are obviously linked. And when it comes to writing, I mean, I think that's mostly what I focus on. Like the connection is what leads to all the feelings that come out with building the story.
How does that work in your relationship now with your husband and in the writing and then coming home and not being able to sometimes download? I can't even imagine. I mean, I think as women, we experience this quite commonly, right? Would you agree that you come home and after a difficult day, like I remember with during COVID, going to the hospital, I used to think, well, I'm going to die, because I'm going to be exposed to something and I'm going to bring something home. And what's going to happen in the hospital in those early days, we didn't know, and that uncertainty, that it was very complicated. And going home with that emotion felt I had to tuck it away. I had to really put it aside and say, yes, things are happening, but there was no disclosure of that experience. And I think that happens in difficult cases and in difficult experiences. Sometimes words are not enough or the emotion stays very held. And for me, writing was really about that. And I don't know how that comes for you in that experience, if there's been, especially with a husband who is also a surgeon and shares sometimes of similar experiences.
Yeah, I mean, you mean specifically like the transition between like work and home. I think we've talked about this before. Like, how do you switch gears so fast? It's such a crazy thing. Like, one minute, the patient's sats are dropping. Like, you've extubated and you're just like ready to leave. Your day's done, and then all of a sudden the sats are dropping, and all of a sudden I'm like, do I need to do a crike here? Like, what's going to happen with the airway? And then it's all fine at the end. And then you just go home and you're like, then the next job, which is being mom. And they don't care what you were doing. They don't understand, nor is it their job to. I don't expect them to. I don't even want them to. I want them to want me as mom. But how do I show up as mom when I've given my all to something else? And it feels wrong. There's so many feelings associated with that. There's guilt, there's fatigue, and then there isn't a lot of reserve because there's no family around, and my husband has the same story to tell. He may or may not even be home, but if he is, he'll have the same story to tell. And so where is the reserve for that? And so I think for me, as far as the job itself or just like my balance, I have to be really careful about how I balance my life so that I can show up how I want to show up. And so that means like really figuring out like how many patients can I see? How many surgeries can I do in a day where I can come home and show up the way I want to show up? What do I need for exercise, like self-care, like to be able to show up like this, like so diet, exercise, and like the less patience and saying no to a lot of meetings. Like I have very few slots for meetings, and you either want the meeting with me at this time or I'm sorry, and it's not going to happen. And so there's a lot of no's, and that means that like as far as what I thought would be like my trajectory as a surgeon, like what generally we would just aspire to, like we always going up and up and up. And so, okay, there's associate professor, then there's professor. And then there's like, well, if I want to make an impact on a national scale, then there's all this research, and then there's the meetings, and then the national meetings that you would travel to, and then the meetings or the committees that you would be on, like as part of that. It's just no, because I can't do all that. And now I'm really into a lot of social justice, mutual aid stuff in our community, which is much more important to me. And it's never going to go on my resume. And it just, I find a lot more meaning to it. So that's the trajectory for my career. And it's just more joy based.
Yeah, there's almost a decolonizing kind of like process here,
Sure.
right? Like medical training has been sold in a certain way. There's this power balance, and this is the one way you kind of climb, up. And we know that the playing field is completely against us, right? As women of color, as mothers, there's just multiple ways, and exactly the way you describe is like on a on an everyday basis, there's just not enough time to be able to do it that way. But I love that when you engage in the work authentically anyway in your everyday life, the work kind of becomes the way, right? It may not be being valorized or rewarded or counting towards quote unquote promotion, right? But the depth and the horizontal growth that you're having. And I love that, social justice and narrative medicine are really just interconnected parts of, right? Like just how we understand what are the particular stories that are living through these impacts of the system that we're in, and how do we describe them? There's not any randomized controlled trials that are going to ever delineate those. It's going to be narrative work. It's going to be the storytelling of the particularities of the injustices. It's not until you know that the patient in front of you had to take 2 buses with 3 kids in a stroller that it really opens your eyes as to like what it means that they're 10 minutes late. It really informs everything. I love that, there's this kind of rebalancing, but it feels powerful. It feels,
oh yeah,
grounding. It's beautiful.
Yeah, it is. And there's obviously when you attach money to something, then like it just becomes about money. And so like that's what healthcare is, I'm there to make money, my patient's there to make the system money, and that's what we've been reduced to on a large scale. And the more we call it out, the more we can fight against it. And I think I can see different opportunities where I've had to do that, like such as I don't work on Fridays. Like I've blocked off Fridays. They're not for any scheduled things. Like it's administrative time. But I got a lot of pushback from that, like for well, I go to 3 hospitals on Friday, or I operate on Fridays. And I was like, well, I don't want to round on Saturday, and I have prayer at 1:00 because I'm Muslim. Not that I want to work on Friday, but I just don't want to have I don't want to be in the middle of a case at 1:00. And if you have a bunch of hospitals going on Friday, let's work on making your life better instead of making my life as bad as yours. And then I think what kind of comes along with that though is you have to really be very good, because you can't be incompetent and say that you don't want to do all that stuff. That's just not going to work, So like I think that's always been like really important to me is like you got to make sure you're really good at what you do. I mean, all of us should when we're dealing with patients' lives, And so then I can say stuff like that, and if they don't like that, then you have to be willing to walk away, which is another very powerful thing. It's being willing to walk away.
Yeah. What do you feel is missing as a professor at UCSF and in medicine right now as you see it? I always felt it was very important for residents and students to have that experience of contact, of patient bedside manner, and that approach and that awareness. But I do see more recently that has become diminished and that has changed, and there's less contact at the bedside. But what do you feel is missing in education and training, and since you train residents and students currently?
Yeah, that's a great question. I mean, I think if you ask a student or a resident that, and then you ask an attending that, then you'll have very different answers, right? And I think from a resident perspective, and I totally see this, I'm guilty of this as well, is that now that, because we've monetized everything so much, productivity, like there isn't as much time to teach. And I had that when I was a resident, I was like 7-8 years ago, where you could see people were just so busy. They were just so busy. Like they couldn't necessarily give you parts of the case to do because there were so many cases to do. We'd be there for hours longer than we needed to if they did that. And so there was that's still an issue for me. It's in so many different ways. Like I don't want to spend that much more time. I can't. And then show up to the rest of my life and my patients the way that I need to, in the office as well. Like if the patient are scheduled, sometimes there's 3 patients scheduled at the same time. And then 15 minutes later, there's another 1 or 2. And then 15 minutes later and blah, 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 and so on, right? And so like how much time could you really give to a resident to go in before you and actually see this patient when they can't close anything up, And then you go in, and depending on how much they got done, you got to just take it up. And so how much time does that give me with the patient? It's a very challenging system, and it's all capitalism based. Like these problems are capitalist. I think that's probably the number one thing, is that we just don't have enough time to invest in them and make money at the same time, which is what we're meant to do. But I think another issue that I feel is important is that I don't think that the trainees actually are as hands-on as they could be for whatever reason. I don't know if it's something that starts in medical school or if it's a cultural-based thing or if it's an East Coast, West Coast thing, because on the East Coast it was a bit different where I trained. But I do think that residents, trainees need to take a lot of ownership because it is one of the very few still like apprentice-based models that we have. I'm speaking mostly of surgery because it's my only experience where it's kind of like you do have to soak it all in from seeing. And so you have to be a very active, engaged learner. And you have to think of every experience you're having as this could be my future patient. What would I do? And what do I need to extract from this situation versus just like showing up and trying not to get yelled at, or showing up and trying to figure out how to do it just so the way the attending wants it, and that's part of the culture that we as attendings need to breed too. But I think taking ownership, these are, 25 to 30-year-old people, we need to be in charge of our education. But at the same time, the attendees need to give them the opportunities to, to try.
Which is a fear of failure. I really think there's a real piece here that's, as an educator, I'm seeing that what we are kind of molding them into is to be, they're targeting, in preclinicals, they're targeting a certain score. It's like, oh, you have to hit that score. It's like, okay, that's what we've just targeted into them, is like study to a certain level and that's it. Instead of studies to understand or study to communicate or even to be able to be like, what am I curious in within this, right? There's just such a kind of overwhelming use of this one way of teaching and evaluation that then we create these machines. Basically, we've just basically spent 4 years programming them this one way and then letting them go into the residency, space. And I've seen this as an attending. I'm like, you're absolutely right. There's like a shutdown. There's like I'll only study what I need to know for the shelf, and that's it. And then it's like, then they're like, okay, I'm done with my day. Like, whereas what you learn is by staying there at the bedside, by communicating, by seeing the next thing that's happening. There's a rhythm to medical care that you learn from. And when we chop it up into these little bits and then we present it to them and then they just swallow it and they think, oh, I know what I'm doing now. I mean, it terrifies me to think that, just so much harm that can be done from just not developing that ability to reflect in action. There's this whole idea of, in medicine, we're supposed to reflect on what we just did, think about what we did right, think about what we did wrong, and then make a plan for the next time. Go, okay, I'm going to change that the next time. That's how you get better. That's how you develop this excellence. But there's such it really boggles my mind that you could be admitting a patient, to your service, but you have no idea just what happened to them in the emergency room and this and that. Like, you have no idea of what part of this patient's story you are in.
Yeah.
Right?
But I want to challenge this a little bit. I want to challenge this because I think, we're talking about the system as it is right now and what it's become and the tension that you describe between time and, contact and, experience and training and developing the resident skills and as well as your own and, ensuring that it's a safe, done safely and the outcome is best oriented around what the patient needs and recovery requires. But I want to challenge this idea, though, of contact, that patient and healer contact. Even in the 5 minutes, there's so much that can happen in the 5 minutes of just listening, just that awareness, just observing and really listening even to the type of words that the patient uses. There's, you can observe even just how their body language, where they look, how they talk, the pauses between their words. Where does the voice crack? Where does it sound more pained? The words that they use and what comes up. And I'm wondering if in healthcare we can do what you do, Farah, is step back after the situation and really write to that. Have residents and students really write a story about what they observe rather than a case report or, where it's really very objective and it has to have a differential diagnosis. But really, if we just really focus on the story and describing that illness in terms of story, I wonder how that would change how the resident student would observe their experience.
Yeah, I think that's a good point. And I think there's certain places do that as part of it's the parallel chart, I think they call it. Is that right? With narrative medicine, with the way things are, I don't see this happening in a clinic. I don't know. You'd have to have maybe half the patients that I have to maybe do this. But I think it's a really good point. And it reminds me a lot of one of my favorite doctoring poems, which is What the Doctor Said. I don't know if you guys are familiar with reading the verse. Yeah, I love that one because it's this is probably being, as heart-wrenching as it is, it's probably being played out in my office weekly with giving bad news. And I get it from the doctor's side, but these are words that the patient would never say to you out of respect, right? All they'll say is thank you, at the end of the poem. So I wonder what someone observing that interaction would get from both sides, because it's so hard to know. I think that would be a great exercise for me even to do, post interaction.
Yeah. Or write a poem or draw a picture or even just, connect or talk about it. I think what I do think is missing also in healthcare is this time that you described, just stepping away and having somebody to talk to. I think in terms of the training, the burnout that we're seeing is really, really a lot about that. That what you're describing, the struggle between pressure and in doing the work and getting that done and then going home, but also the pulls that we get, and you can really feel it, and that's very fatiguing to constantly carry.
Yeah. Do you find that there's technological fixes that are coming down the pike that are starting to help with that? Like the use of AI scribing and things like that?
I don't know. I don't know if you guys know of any. I haven't used anything. I don't use Dragon. I don't use anything. And I admit my notes aren't the best, but they get it done and they document. But I've heard of people using virtual assistants and for documenting and for even returning calls to patients to get their more time back and AI for their notes,
When I was overseas and I had to take care of children with Down syndrome, I used to have a scribe who sat next to me, and she would put in all the orders, type in all the the words that she was saying, and it really was such a relief. In my head, though, at that time, I imagined a speaker being on the top and just listening in and recording the whole thing. I imagined that, and I said, "Wow, wouldn't that be cool if there was something that was just recording, of course, HIPAA compliant, and it would just record the whole experience, and then we could observe that." I mean, you can do that in terms of videoing it, and there's so much more that you observe and you learn about yourself in that experience as well. So I think that is, I don't know, one way I think that can be implemented.
Because that's what we're trying to do, right? Is our attention is fragmented because we're trying to work on so many different levels.
Yeah.
You're doing a physical exam, you're actually communicating, you're actually doing even some differential diagnostic kind of, thinking as well in the moment. There's so much happening. And then to be able to free up a part of ourselves to notice what's actually happening through the story, right? And we know from just how people tell their stories, what quality of words they use, what their tone is, what their body language is. I can just kind of imagine where there's just these large language models that might be able to look at a patient's story and be like, oh yeah, here's this person of this descent and this is their genetic profile and this is where they live and this is how much we know about them. And they'll just spew out a story, what this looks like. And we may be going towards that kind of space.
Yeah.
So true. I mean, scribing and the use of AI and even what emerges with that collection of data and qualitative and quantitative and how it becomes its own version of something, right? That virtual
the representation, right? Like when we talk about narrative medicine, the representation, when we talk about, it's different when you videotape somebody, it's different when you're audio, it's different when you write notes off of an encounter, and it might be different as a representation when it's been run through these large language models, and those have their own biases as well.
True.
And they're going to be very interesting to see. So yeah, qualitative, quantitative. Well, we've chewed up an hour here chatting about such fun stuff. Thank you so much.
Yeah.
Did you have anything to ask us? Any questions that you like to throw out there?
Something that comes from something that comes from your curious mind.
For future free Sure. I don't know. I think, and it's all integrative medicine and narrative medicine type of stuff. Yeah.
I mean, and consciousness, I mean, they're all kind of connecting up right now.
Yeah. I would say two things would be one would be, and I'm going to forget the second one as soon as I say the first one, but like a lot of my patients have bias against, or just like a barrier to paying for medical services. And I'm assuming you guys aren't insurance based with like ketamine and things like that, right? Like if I send them to my endocrinologist friend who has lifestyle medicine certification and is extremely well qualified, and they'll get more time with her and she'll be very curious about a lot of things, and you'll get your money's worth. But she has a direct care fee. Like people won't want to do that. So as someone who's interfacing between like modern medicine, but also like definitely believes in everything you guys are doing and would love to like, wouldn't be the one to replicate it myself. I would just refer. But patients have like bias against it, like exploring that a little further, and then exploring also like physicians who are not in integrative medicine's biases and barriers to becoming more curious about what is like not evidence-based medicine, or what is evidence-based medicine not taught in medical school that they just don't want to be open-minded about.
Yeah, you bring up evidence-based medicine, and I think is it medicine because it's evident? I mean, do we have to we try to prove ourselves right, and that's what we base our medical experience on. And just because and that may be valid, but there's so much more. And what's not known, what's forgotten. I think when we think about integrative medicine, we're really thinking about ancient healing practices and how they emerged, and Ayurvedic practices. There's solid evidence on that, but not really represented in our medical training and medical experience.
Yeah.
When we bring up evidence-based, it's definitely, I mean, I've taught in it. We've used that framework because we have to have a high degree of evidence if we're going to, approach insurance companies for reimbursement and actually have these interventions. You've got to meet a certain level. Absolutely. And then I feel like that's one model that we can maybe overlay with another piece of it, which is, that holds the boundaries, right? And I love that kind of, I think, oh gosh, I'm forgetting, Siddhartha Mukherjee had kind of like this book about just like the particularities of, there's a quote that's just avoiding, I'll look it up later, but it just kind of talks about the rules and laws of medicine. It's in his book, The Laws of Medicine. Yeah. I really recommend reading it. Some of my students who've read it, residents who've read it, it's just like, medicine is such a dynamic art, right? There's just so much. We're always at the edge and we're always discovering. And like you said, there's all of this other bodies of knowledge that we haven't really had an ability yet to study to that degree from that materialism lens. So kind of like, I love this question that you have of how can we bring in the evidence, and what are the different kinds of evidence is what I kind of start to think about is like, and
or even just thinking beyond evidence-based medicine. Like my patients will frequently ask me like, well, what supplements should I take for a thyroid, or like things like that beyond the scope of a subspecialty surgeon, right? And they'll ask me like, well, what do you think of this? And I'll say, well, I was trained in evidence-based medicine and they didn't teach me about this, which doesn't mean it doesn't work. It just means that I don't know very much about it. And it could work, and as long as it doesn't have a downside, which I don't think it does based on whatever they're showing me, then try it and see what happens.
Well, I now believe this thing about cellular health, and cellular health can be impacted by medications, by supplements, even by emotion, by joy. I mean, when I feel joy, I know I feel it. I can feel it in my body. I can feel an energy. I can feel, an activation. I can feel an awareness. That is in the cells too. And I've had patients who have had very significant chronic conditions and have literally willed their way through that. Willed their way through. I have a stage 4 colon cancer patient who is active, alert, and fights for her life every single day, but with a strong sense of spirituality, a strong sense of awareness and groundedness, and recognizing and really paying attention to her emotions, paying attention to her rage, paying attention and really working with that in that mental health space. And I think that's what sometimes heals too, is this, the internal milieu, right? And really really working with that internal milieu as well as the external, and bringing and uniting that external part of you and the internal part of you, and really tuning to your environment. And that has an impact as well. I mean, if I have a patient who's going to have a toxic illness, diabetes, for example, and goes home to a toxic environment, of course it's going to get worse, right? But if that same patient goes to a home that's supported and guided and loved, what do you think that impact is going to have on the condition? And this is something we don't talk about in conventional spaces.
It's very simple. It's normals teach us rules and outliers teach us blogs. I thought you would appreciate that as a surgeon, right? It's like the normals teach us the rules and the outliers teach us the laws. So it's like we're always in that liminal space of, things that we weren't taught in medical school because they weren't discovered when we went to medical school, right? Like my parents, when they went to medical school, DNA wasn't being taught. Those discoveries occurred as they were graduating. And yet we took that as the basis of our understanding, right? And the same thing with the next generation of physicians who are being trained. And so it's almost like we're learning a new way of apprehending the same thing.
Yeah.
From a different lens.
You also asked about the patient's pain and having that grudge, that grudge feeling about pain. I think what changes that aspect, at least from what I'm seeing currently, is that time, that sense of knowing that patient, giving that patient an hour or 2 hours sometimes, sitting with them, listening to them, really being unconventional in your space, right? In yourself, and doing all the same thing that you would have to do in conventional medicine, but really giving it time. And I think that time factor is something that patients do miss, and they pay for that, recognizing that that's the quality of what they're going to be getting.
Yeah, insurance isn't going to cover the extra time.
I think of what patients like. There's this feeling that healthcare should be free or mostly covered. And so I'll literally tell them, like, you should go see this person, because if they have a very non-specific complaint. Now, if you have something really straightforward, like it's hypothyroidism, you just need someone to write you the levothyroxine, then fine, you can, see any endocrinologist or whatever. But if you've just non-specifically feeling very fatigued, and this is very different for you, and nobody has found anything on the normal testings, and you might need somebody to just be very curious. And that means that you should, see someone who can ask some better questions, think outside the box, and sometimes still patients won't do it. And I think maybe that's just something that hopefully it will change with time, and maybe marketing, and I think hopefully the tide will shift from these modern models of medicine in these employed practices where everything's insurance-based. And I think that I would like to see it change, and maybe I'll have more courage to go outside of my model, more hers now.
How about you brought that down? Because you're right, there are certain patients for whom it's like one and done and go through, and then there are certain patients who need that extra time and that space and that complexity. And how amazing would it be to even envision spaces in which both of those things are available? You just know how to basically maneuver between the two in a limber way. Right now, the way we have it is just, it's thickets. It's like, oh, you want to find a therapist, you want to find a doctor, you just have to do this and do that and go through all of those processes. I think patients are also, more than ever in history, better read, better informed, but also that makes them vulnerable to a lot of the marketing stuff that's happening. So the role of the physician has kind of shifted even to kind of encompass that and be alongside that, but also still be, like you said, have that evidence-based mindset so that you can help your patients decide, you want to ignore those three things, but this one looks like it, it has some good evidence behind it. So let's try that. And then here are some effects that might happen, so kind of being a real guide alongside.
Yeah.
Well, something we've also talked about is why wait for something to really pathologize to that degree that you'd start to treat it. Why not treat something like a thyroid condition earlier, treating the health of the thyroid, not the pathology, and really focusing on what can make a thyroid more healthy. How do you sleep? How do you regulate your body temperature? What do you do, in terms of infection? How do you help yourself? I think even just thinking through that and saying this is how also one can really.
Yeah, there's a lot of knowledge there about these. Absolutely. I wish we could, place all of this in the teens and 20s when we really need to learn these things, when we're starting to take care of ourselves, right? When
Yes.
it's not, we're seeing more and more of, like, for example, thyroid illnesses that you brought up. When my daughter moved to the Southeast for college, she had her first bout of thyroiditis. And it tracked with being there and then coming back here and then going back there again, which just tells me that it's your environment. Most of the time, it's the quality of the water, it's the soil, it's what foods and the things that we don't really measure eating, which is really fascinating.
And it's also a scary time where we're not sure whether to trust our environment. Like, it's getting more and more to that point where I think that if we, in this capitalist colonial environment where everything is monetized, can we trust our water? Like, can we trust our food? I think there has to be a lot of education around that as well, because like kids these days, are they going to eat an apple or are they going to eat chips? And the chips have red dye in them, all kinds of things, like they have so many different things, and parents don't necessarily know either, or they can't afford this better thing. And then we're taking farmland away from people, and like we're getting our produce not at the farmer's market from our local farmer, and all this kind of stuff is all connected. And I think like we need to connect those dots more than ever, and that's why like I think it's physicians' jobs to do that.
Yeah, you mentioned, your work in social justice outside of the work that you do. And I disagree. I think your work is so related to what you're doing on the outside of your teaching and surgical world is very, very much related to what shows up in your office or in the surgery.
It's true. It feels disconnected because it feels like I'm working in a business at work, because of the way it's set up.
Yeah. And that's such a kind of, I think, what you've just described, the trust that's being eroded, like you said, in our water, in our soil, in our food supply, the trust in the healthcare system too, kind of is following suit. And we're all feeling that, some of the ways in which our healing spaces have shifted have made all of us physicians really understand that it's not us, right? It's the way the system is set up. And also our powerlessness comes from the fact that you could see the same patient with that same diagnosis and know that this was a diagnosis related to something in the environment, for example. And there be not a lot there to support you in changing that in a real way for the patients in front of us. It's happening in pockets, a disability that I think we're starting to see where physicians are reaching into environmental justice initiatives and, making sure that fresh food is grown and patients have access to it. But those are just like, we need 100,000 of those right now. We need to get those out of the experimental phase because we know what works, right? We know that.
And I think it's also like boycotting certain products like that are just everywhere, and I don't know if people are willing to do that for their own health or for the health of their kids. I actually don't know if people are willing to do that, but I think it's really important. There's a few companies that make all the food that everybody's eating. And there's a lot of additives in the vast majority of those things. They're packaged goods. They're bad for the environment. They're very bad for our kids. And this is like the first generation is going to grow up like entirely on such foods. And we don't really, it's a grand experiment. And we see a lot more cancers, like a lot of younger folks getting a lot of cancers, like colon and breast. And that's like, a lot of my colleagues are saying that I think they should change the age of the first colonoscopy to be younger because they're seeing so many more cancers now. And thyroid cancer is on the rise as well, which is a lot of that could be related to microplastics, could be related to additives in the food. And how are we going to change that? I mean, I think it's boycott. But I don't know if people are awake enough to see it and to change the way that we buy because we're just so into convenience. It's part of the capitalist, colonialist environment. And so I think
our choices are weighed towards 90% of them are going to be the choices, right? Like the choices are marketed in that way, priced in that way, access to them is provided in that way that the choice is already made for you.
Yeah.
In a way, right, through your own kind of behavioral economics and everything. So it really is, I think physicians are at the center of this because, like you said, colon cancer, everything we put in our guts ends up, right? Breast cancer, anything that is fat soluble ends up there, right? And like you said, the thyroid and the endocrine system, anything that's microplastics is up there. So it's like our bodies are telling us something, right? That's the story of the body. The human corpus is speaking, and if physicians are to do a proper interpretive diagnosis, really, if we're really going to say we're making the correct diagnosis, it has to involve all of,
Yeah. So I really don't talk about any of these things like by themselves. I think that it all has to be very connected. And I think physicians need to be loud about this. We can't talk about people's health without talking about social justice. We can't talk about it without talking about decolonializing our culture. We can't talk about it without talking about anti-capitalism. And it's not popular things to say. But I can't not talk about this.
Well, I think the evidence would have to come. Well, one thing I do on intake on patients is check their CRP, and I'll tell you, 8 out of 10 patients have elevated inflammatory markers.
We're just walking around.
Just walking around with an elevated inflammatory. Obesity is an inflammatory condition, and it's been shown to be inflammatory in the brain. Now we're doing brain maps, so you can actually see inflammatory changes in quantified EEG. I mean, it's there. The evidence is there. And you're right, being very vocal and very, sharing to that evidence, right? Because that's how
it would make legislative change. It really is going to take, a real concerted effort, just like we got lead taken out of gasoline, right? Like that was a concerted effort. There are stories of exactly how this works, and it is through the storytelling, connecting with the real-time evidence-based data that's coming out and then driving change, right? So I feel like really at this, yeah.
And so, what are some of the advocacy programs that you're working with? How would people can learn more about what you're doing?
I would say, I would recommend work with local organizations. So, finding common or people with like-minded attitudes and kind of form teams. There's not going to be people that you necessarily live next to or people that you work with who are going to have maybe vastly different ideas of how they see the world than you do. But when you go meet up with people who are also interested in caring for the homeless or homeless advocacy, for advocating for Medi-Cal patients, for Live Again Fresno, which is one of the organizations at Fresno I work with that I really recommend. When you see these folks come together, you may have nothing else in common with them, but you have the most important thing in common with them, which is that you guys, all want to see social justice. You want to see that the people that are being kept down by systemic violence how can I help these people? How can I help the homeless? There are good people out there doing good work, and just be connected to them. Mutual aid is a big thing now, especially just now that the government is, defunding a lot of aid services. We have neighbors helping neighbors is a big thing. If you have extra fruit, see if you can share it, take the food out of our government. They're going to pull the food that they're giving kids in school now. So how can I share my extra fruit? How can we grow food so we're not relying on somebody else? We started something with just these same folks that I just came to know through this mutual aid service, where instead of calling the police when you have escalation of domestic violence or disputes or a mental health issue, to have a hotline, and we're taking call. We're going to start this in April. We're in the process of training and developing it now. But it's just 6 of us. We don't know each other in any other way, but our desire to help the homeless and do these kinds of things. We like some homelessness stuff together. But I had this idea to start this hotline, and hopefully it can grow. And then if they're not calling the police, we all know that I don't know how many police calls, police shootings that started with calls like this, that the police came to instead of de-escalating or helping, because there's no other way in American society. Who do you call in situations like this? If you either call the ambulance or you call the police. But if you call the ambulance with a call like this, the police will also come. And then, in a larger percentage than you would think, those could end up in a shooting. And so demilitarization, all these things go together. So that's what I've been working on. And it's not enough. it's not at all enough. Not even a little bit. It's almost feels like it's not even worth saying the things that I'm doing. But I do believe that feeling that it's not enough is a great way to get yourself out of doing anything at all. And so that little bit, the little bit, those, I told you about those chickens, the 15 chickens every 2 weeks with the kids from the motel families. Like I started that in COVID, every 2 weeks, getting 15 Costco rotisserie chickens. Now those are 30. And there's like a fruit that goes with it. And over 4 years, that's more than it would have been. It's whatever number of chickens more than it would have been if I had just decided that that was a useless thing to do,
Yeah.
It all adds up. So
bringing that attention, you get to craft where your attention goes. I think what you're describing is the anchors of attention, right? It's like you're bringing, taking time and you're saying, I'm going to limit certain things. I'm going to say no to things, but then what do I give that time that I got back out of the capitalist system, right? You're literally right, you're donating your attention and you're actually, that's the worth of it, because it would have, had you an hourly rate, right? Made money. There is an actual hourly rate that you can apply to the attention that you've given to these other projects. And we say that when things don't, we devalue things when they quote unquote don't make us money, but that's also just the way we've all been kind of, like that's our psyche, because that's how we've been programmed. But to value things that don't make money is actually the higher good, right?
yeah, and that's what capitalism is. The only value is money, where the value is actually human life.
Yeah, changing that. I love that, when we talk about curiosity, we talk about opening up the box and thinking out of the box and really asking those questions and really thinking about, it doesn't have what it's this way, but why is it this way and what else, and I can hear that in the work that you're doing is really just stepping out of the zone and really just saying, hey, there are other ways. And we don't even this idea of value, right? What is value? Is it an RVU value or is it the human life value? There should be a quantified value on human life. And if we could quantify human life, then we would put value to it.
Yeah.
Thanks for
Wow, thank you for your time.
Thank you both as well.
Thanks for joining us on the Two Curious MD podcast. We hope today's episode inspired you to ask new questions and explore fresh perspectives. We challenge you to ask us those unasked questions that you're curious about in your medical practice, condition, health, and wellness.
If you enjoyed the podcast, don't forget to subscribe, share it with somebody just as curious, and leave us a review. It helps us keep the curiosity alive. Post or comment with a question or curious inquiry that you have and seek to explore or learn with us. Stay curious, and we'll see you next time.